we'll be discussing a meta-analysis that the platinum doublet chemotherapy as a second-line treatment for relapsed patient with non-small cell lung cancer. It's a systematic review and meta-analysis. Next. We all know this, that a small cell lung cancer, it accounts for nearly 15% of the cases, and nearly 70% of the patients have an extensive stage disease at diagnosis. Next. Now the management standard first line, we all know this is platinum chemotherapy or the checkpoint inhibitors in combination, but invariably most of the patients relapse, and platinum doublet chemotherapy is commonly used even today in relapse cases with a disease control rate of nearly 65% and overall response rate of 40 to 55%. So second line platinum doublets may add an additional option to the narrow range of options available. Next. Now in this meta-analysis, this systematic review and meta-analysis illustrated the reported outcome of platinum doublet chemotherapy as second-line treatment for relapsed patients with a small cell lung cancer. Eligible clinical studies were identified using PubMed or IMBAS. Relative risk of objective response rate and disease control rate of second-line chemotherapy was evaluated. Subgroup analysis were conducted to focus on the comparison with standard second-line regime and sensitive relapse. Progression-free and overall survival and adverse events were also reviewed, and the study selection was very stringent. Means out of we see that on PubMed nearly from 661 and nearly again 650 patients on the MBAS. Final studies which were included in the quantitative synthesis, that is the meta-analysis, was just 10. Next. And in this meta-analysis, 10 observational and randomized controlled trials were enrolling a total number of nearly 1,200 patients, with 438 patients with the second-line doublet chemotherapy and 784 patients with the second-line non-platinum regimes. And these are the few studies for which we have significant improvement in the PFS and OS, which has been highlighted. So those patients who were in the platinum doublet group, even in the relapse sensitive patient, platinum sensitive patients, those who received again re-challenge with the platinum doublet, they have at least numerically better PFS and OS. Next. Now coming to the tumor overall response rate after second line platinum doublet regime in the sensitive group, we see that the platinum doublet versus non-platinum regimes in the entire 10, taking the entire 10 studies, we see that the relative risk is 1.527 with a significant p-value. Again, if we compare the platinum doublet versus topotecan only in the non-platinum group, again the platinum doublet fared better with a significant p-value and a better relative risk reduction. Again, platinum doublet versus either combination of amrubicin or topotecan. Again, here the platinum doublet fared better with a significant p-value. But if platinum doublet was compared just with amrubicin, it was not significant. So in sensitive relapsed patient, there was a slight trend towards second line platinum doublet group versus non-platinum regime. However, the difference was not significant. In the subgroup analysis indicate that even with slightly decrease in the relative risk, platinum doublet group had favorable efficacy over the standard non-platinum regime. Next. Again, disease control rate after second line platinum doublet regime. Again, here the story repeats same. If we take the platinum doublet versus non-platinum patients in the entire 10 studies, taking together, the platinum doublet fared better in the disease control rate with a significant p-value. Again, platinum doublet versus the individual agents, if we take topotecan or amrubicin, again it was better in the platinum doublet. Again, with the topotecan only in the non-platinum group, platinum doublet fared better, but there was no difference with the amrubicin group. So when only sensitive relapse were included, platinum doublet groups showed a favorable disease control rate compared to the entire non-platinum group. Next. Safety profile with a re-challenge of the platinum, we see the hematologic toxicity numerically. Again, the platinum doublet was less toxic as compared to the topotecan or the other non-platinum group. Febrile neutropenia also, it was numerically less in the platinum doublet group. And non-hematologic toxicities over grade 3 were observed in only 2 studies. Next. So, uh, in a financially constant setting, these studies can be we can take it as a practice changing in this meta-analysis. So second line platinum doublet demonstrated a significantly higher overall response rate and disease control rate compared to non-platinum regimes. PFS and OS were also better, and adverse events were tolerable in the platinum doublet group. A second line platinum doublet for a small cell lung cancer can be a reasonable option, especially in the financially constrained situation. Thanks.